Dr. Angela Eykelbosh is an environmental health scientist and knowledge translation specialist who works on a range of environmental health issues. In response to the COVID-19 pandemic, Dr. Eykelbosh and the team at the National Collaborating Center for Environmental Health have dedicated their efforts to gathering and synthesizing public health evidence to better understand the risks of disease transmission in indoor environments, including homes, workspaces, and public settings, as well as the tools and strategies to mitigate risk. And for more information on the NCCEH's work, you can definitely go to the website, which is www.ncceh.com. And .ca. With that, I will hand this over to Angela. Angela, welcome, and thank you for joining today.
Thank you very much. So you should be able to see me, hear me, see my screen, hopefully. Tell me
if you can do all of those things.
Great. Then we're not having major malfunctions today. So as Sarah mentioned, I'm going to be talking about the role of, I have HVAC here in the title, but I'm actually really more talking about the role of ventilation generally rather than specific HVAC systems in the public health response to COVID. So this is just born out of a lot of work and research and literature review being done at the NCCEH, as well as some work on a working group that Sarah was also a part of, so she knows all this stuff too, and I'm sure she'll point out all of my mistakes. All right, how do I advance? Okay, there we go. So if you haven't heard of the NCC before,
Hang on 1 second, Angela. I have one person online saying they can't see the screen. Can others see the screen?
Yes.
Most people can see it, so it does seem like a problem for one individual. Maybe try logging out and logging in again. Okay, go ahead.
Oh, it's too bad because the first slides of this are just riveting. So the NCCH is part of a group of 6 sister NCCs across the country that were part of the National Collaborating Centers for Public Health generally. So we were actually established by the Public Health Agency of Canada back in 2005 in response to the first SARS epidemic, just in recognition of the fact that we needed more KT capacity in Canada around public health and exactly these types of emergencies. So we exist to promote that kind of evidence-informed public policy. We do a lot of, our base tool is evidence-based knowledge synthesis and translation. We also try to identify the knowledge gaps and seek answers / research for those. And probably our biggest role is to foster those networks and build capacity for Canada's public health system. So today we're going to be talking about many interesting things. We're first going to be talking a little bit about some of the really great aerosol science that has come out and what it tells us about this issue of airborne transmission with COVID. We're also going to be doing a little kind of mini review of some of the literature on where and how people are getting sick from COVID. This is really important to kind of contextualize the aerosol science coming out. We're also going to talk super briefly about communicating airborne transmission, just because this has become a particular risk communication problem for mostly me, but also other people. We're also going to talk about some recommendations for ventilation in indoor environments. And we'll talk about some of those knowledge gaps / canyons that exist out there. So the evidence really supports, forgive me if this is already old hat to you, but kind of 5 potential modes for aerosol transmission. One of those, or 2 that the most important, the primary means are of course direct contact and those really close range respiratory droplets where somebody's, is directly inputting into your breathing zone and your face and your eyes. So fomites, which are refers to transmission through indirect contact with contaminated surfaces. We don't actually have a ton of evidence for that. There's a little bit of evidence for that, but we assume from other respiratory diseases that fomites are a very important thing, just maybe not easy to identify specifically. Aerosols is something else we'll be talking about. Aerosols refers to transmission via the smallest particles that are out there floating around, anything kind of less than 5 or 10 or even 20 microns, depending who you ask. And there's also a little bit of evidence for a virus that is shed through the feces. So we won't really focus on that, but I'll kind of touch upon it once or twice. So The really important question that is being posed out there in the world of, ventilation and COVID and our indoor airspace is safe is, what is the role of aerosols in this pandemic? So there's kind of various different levels of evidence, and I'm going to go through these with the least convincing to the most convincing, and then I'm going to try to put them in the context of where we actually see people getting sick. So many of you will have read, there's a couple of papers out there where labs have artificially generated viral aerosols that remain infectious for surprisingly long periods of time. Some of them were a couple hours, one of them was for up to 16 hours. So that was a bit unexpected. It was also perhaps not super relevant for like the real world. And so, but it's good to know that these things, once aerosoled, can remain viable. We're also seeing lots of studies out there, both modeling and actual visualizations of people themselves generating aerosols. So there's been actually quite a bit of work on this for influenza and other diseases going back about 10 years, but now there's more and more papers about people generating droplets and aerosols and, being able to find actually COVID virus in that SARS-CoV-2 in those droplets. So the amount of the droplets you're producing and the size of those droplets is of course dependent on your activity. So the forcefulness of the activity, the intensity. So, breathing is producing small droplets and fewer droplets, whereas sneezing is producing a large range of droplets, including some really big chunks and also a cloud of aerosols. So there's also been quite a bit of work on aerosol dispersal in hospitals. So viral RNA, this is just the RNA, so it doesn't tell you whether or not the virus is active or infectious, has been found in the air and surfaces all over the place in hospitals. So obviously it's often found on personal items like the remote control, toilets, door handles, anything that you touch with your body is, if you've got COVID, you've probably deposited some viral RNA on that. However, it's also being found in places where you wouldn't necessarily expect people to be touching, like the floor under the bed, windowsills. They've also found the virus on exhaust grates, which, when this sort of evidence comes out, people get really excited because it's in the ducts, But in fact, if you look at how a isolation room is built, and this is an isolation room is where COVID patients are kept, it's got negative pressure inside so that their air can't seep out to the corridor and potentially affect other people. So you've basically got a negatively pressurized, the room is has negative air pressure, and that causes airflow from the corridor through the door. There's also supply that's providing air, and then there's an exhaust that is sucking the air out of there. So an exhaust grate is exactly where we would expect to find virus, especially because those grates are usually placed pretty close to the bed, sometimes right behind the patient's head or above the patient's head. So if they're in bed and they're emitting anything, it's probably going to be entrained and sucked up into that grate. So that's what you would expect. There's also one study that looked at, I think 3 different air handlers in a hospital, and they found viral RNA. So again, not knowing if it's actually viable on the pre-filter, on the final filter, and even on the supply damper after the filter. So this is also cause for concern because we would expect those filtration systems to take out the virus, and in fact, they do take out most of it. In this particular case, it's important to note that they were just looking around. They were just investigating generally. There was no associated transmissions with this. So again, you would expect the virus to be sucked up by that hospital HVAC system and carried away. So it's not actually unsurprising to find it in the air handler. The other important thing to note from these studies, although it's often not emphasized, is that there's a pretty stark difference with viral RNA contamination on surfaces that were recently cleaned versus those that have not been. So cleaning and disinfection are very effective for this particular virus. If the surface is cleaned, it usually has very low contamination or no contamination. And for all the studies that have found this kind of widespread contamination in care environments, there's an equal or greater number of studies that find little or no contamination. So there's definitely an element here of, how effective are cleaning procedures, how many patients are you handling? But it is very, very much possible to control this surface and air contamination in hospitals. So is it infectious or not? And if it is it of significance? So viable virus has now been cultured from air samples. So previously, we're finding viral RNA everywhere, and people are like, oh, but it's not infectious, so it's not a big deal. But in fact, the air sampling method itself destroys the virus. So there was not really a great way to know, but a couple of people have worked it out. One study found viable virus in the air up to about, it was slightly less than 5 meters away from a patient, and they did some sequencing, and it was in fact the same virus. Another study really focused on fractionating the sample, the aerosol sample that they collected, and they managed to culture the virus from the very smallest submicron fraction. So that's very interesting. So it's infectious, it's in aerosols, it's in the airs. Is it of significance? So the reason why we ask that is that, it's in the air, you still have to be able to capture or inhale enough of that to establish an infection. So that requires proximity and time. And we also should be able to see evidence of this in the real world. It is difficult to identify quote unquote airborne transmission, but there should be something out there that is supporting this sort of transmission. So we're going to talk now about where and how people are getting sick. It may not surprise anybody to know that most transmission actually occurs within the home. Where most people get sick is actually in the home, because most transmission occurs within families. So we know this from the big WHO report from China in February that looked at 75,000 different cases. Most of those transmissions in those mini clusters were happening in the home. Qian et al. Also looked at 318 outbreaks in China, excluding Hubei province because for various reasons. But they found most transmissions was again happening in families. Leclerc et al. Did a really nice systematic review of 201 outbreaks, which they classified into 22 settings, salon, workplace, church, things like that. And once again, the home is where most of those clusters were occurring. And Burke et al. In the US, they just they looked at the first, I think 400 or 500 SARS patients that, I could be wrong about that number, that came to or arose in the US, and they found that the secondary attack rate, so the number of people in your home that get sick because of you, was about 10.5% for people in the home, but it was only about 0.5% for non-family contacts. So this shouldn't surprise anybody. This just reflects who you spend time with and your shared spaces. So generally, household secondary attack rates are still pretty low, despite, this is where most transmission is happening, but the secondary attack rate, I've seen various numbers, but it's usually below about 30%. So the people who get sick are usually the spouses who are the caretakers, but they're very rarely the children. That secondary attack rate really depends a lot on whether or not how well people can take care of a COVID case in their home. Like, do they have PPE? Do they have a second bedroom? Do they have a second bathroom? How prepared are they to actually take care of someone? So other outbreaks that we see mostly in the media, these are the ones we talk about the most because they're in the semi-public sphere, are congregate living settings. So seniors' homes and work camps and dorms, prisons. And these are places where they've got those shared facilities, they've got personal care, people contacting each other, they've got social programming. So these are all things that really give SARS-CoV-2 a great chance to transfer from person to person. And just generally, crowded indoor spaces are the place to be for COVID-19. So churches, there's been some fitness classes, meat processing plants have, there's been very large outbreaks, as we know, associated with meat processing plants, daycare, overnight camps, and of course, cruise ships, which in cruise ships, every meal is a mass gathering and it happens 3 times a day. So pretty tricky. So then I often get asked, are outdoor spaces safer, or are they really safer? Or are we just not kind of capturing those kinds of outbreaks? So there was one study that came from Japan, Nishira et al., where they looked at 110 cases and all of their close contacts and where they met those contacts. And basically they found that if the case met their contact indoors rather than outdoors, then they were something like 19 times more likely to pass on the infection to those people that they met indoors. So indoor contact is definitely more risky, and this is something we've been consistently messaging about all summer. However, outdoor crowding is still a concern. It's, you know, we don't want to go too far and say that you can't get COVID outdoors. Of course you can. We know from flu outbreak investigations in the past that crowded outdoor music festivals and other kinds of mass gatherings, you can, at the Hajj, you can still definitely pass COVID or influenza in a large crowd. Also, one of my colleagues at the NCC is working on this, is to beware of those quasi-outdoor spaces. So if you've got 20 people on a patio in the summer, but then in the winter you put a big tent over it, is it still an outdoor space, or can you still have 20 people in that space? That's something that we need to think about. Converting these outdoor spaces into what might actually now be indoor spaces from an infection control perspective. So there's one I get asked about a lot, is about multi-unit residential buildings, or MURBs, condos, stratas, apartment buildings. There has been a few outbreaks worldwide, but actually very, very few. And so I really want to emphasize that we really don't see a lot of condo or residential outbreaks that are related to the building itself rather than groups of people that share that building. So for example, in Hong Kong, there's the Hong Mei House, which some people may have heard about back in February. It was related to, potentially related to actually a faulty sewage pipe. I'll talk more about that later. In Berlin and Göttingen in Germany, there was a few residential towers that had outbreaks, but they appeared to be more related to the communities that lived in those buildings and how they interacted inside and outside of those buildings rather than the building itself. Verve Condo in Calgary, this happened this summer. You might have, there's quite a bit about it in the CBC. I don't think that Alberta Health Services has put out a final report on that, so I'm gonna just pass that by. In Melbourne, just recently too, in August, there was, during the most recent lockdown, there was about 9 residential towers that were locked down quite suddenly and forcefully. And it had to do with the fact that there was 23 cases in there, but they thought that there was potentially hundreds of cases. So they eventually narrowed it down to 1 tower, but they kept that tower locked down for 2 weeks. And there hasn't been any word on what they think what it was. So people can and do isolate safely in condos and apartments. So I know a lot of people are worried. They think of I've seen a lot in the media lately about building managers who say, well, if I manage this building, shouldn't I be notified if there's a COVID case in my building? And shouldn't I be alerting everyone and posting signs? And the answer is no, because people are entitled to their privacy, and also people can isolate safely in their building if they do things like minimize their interaction. So they should not be using the common areas. They should be staying in their apartments. And also, you know, if there's rigorous cleaning of the common areas, that should prevent any outbreak. And shared laundry rooms is something that we've talked about quite a bit at the NCC. We actually have a poster on our website. It's available in 4 languages for these shared laundries. If you have an older building, you might be using the same machines, and it's actually quite safe to do so. There's just a couple of pro tips for how to use those machines the most safely you possibly can. So you can go to our website or email me. I'll be happy to send those on. So the reason why I've blathered on about all of this is because we really need to have a firm understanding of the risk factors for COVID-19 transmission before we talk about ventilation and airborne transmission. So there's individual factors, of course, and that's things like how sick is the index case? Are they symptomatic? Is his or her virus still replication competent? And that is playing off against the condition of the contact. How susceptible is that contact to actually picking up the disease? We know that the most important risk factors are hugging and touching and being close. That proximity is the problem, alongside spending time together. So your risk of getting COVID is a factor of your proximity and the duration that you were in that proximity. Those are the 2 most important factors. Being indoors with others is definitely increasing the risk. If that space is unventilated, then yes, that's most certainly increasing your risk, and we're going to talk about an outbreak next. And if you're doing activities that pump out those particles, like singing and cheering and I guess screaming in each other's faces, then you're increasing risk a little bit more. And then of course, fomites. As I said, there's not a ton of evidence for transmission through fomites, but we know they're kind of there. They're probably just a part of the mix, and it's going to be very hard to pick out their particular role. So I'm going to talk now about one particular ventilation-related outbreak. There's been quite a few. There's been actually quite a few outbreaks that people have said, well, this is evidence of aerosol transmission. But when you actually look at it quite closely, it's not that compelling. This is one that I actually do like to look at and talk about because it's one of the very, very few studies where they actually looked at the ventilation. A lot of these studies say it was the ventilation, but they didn't actually do anything to evaluate the ventilation in place. So this was the second paper of the Guangzhou restaurant incident that happened early on in the epidemic or pandemic. And this is the references below. But the reason why I wanted to bring this up is just to show the many ways in which ventilation contributed to this particular thing. And once you realize all those pieces are in place, and what happened is actually not that surprising at all. So you've got this long kind of oblong room, and at the top there is where the index patient is sitting at the middle table. And then there's two tables on either side of her. So they're all the way up here. The only fresh air, the only outdoor air supply to this entire room is this emergency door down here. There's actually no mechanical ventilation. There was no fresh air supply to this entire room except for this door that was opened once in a while as somebody used it. And so they did some modeling and some tracer gas and some other, used some other tools, and they estimated that there was less than 1 liter per second per person supplying this room when it should have been somewhere up around 8 to 10. Also, the exhaust grates, these little blue things here, these exhaust grates were all closed, which means that there was no potential for airflow to happen through the space. They also had these AC units here, so they had these mini splits up on the wall, and they were all kind of blowing horizontally across the room, creating these kind of air zones, essentially. So what this really did was it created this little pocket at the end of the room where that sick person happened to sit. And as a result of that, there was transmission to, I think, 8 other, maybe 9 other, I think it was 9 other patrons. And the farthest patron away was this person right here, patient C1. They were 4.5 meters away. So that distance is actually not very surprising to me at all. This was a very small space. They were there for, I think, 60 to 80 minutes. And so it was, this does not surprise me in any way. For all we know, there could have been another case, COVID case, sitting out in this area or sitting over here. But, you know, because of this, it's back in this particularly really bad pocket that the transmission to these other 9 people happened. So the reason why I'm bringing this up is it's actually really consistent with other quote unquote ventilation outbreaks that we've seen, mostly from SARS-1, the first SARS, and flu, where we have usually hospital wards, are most of the studies I've looked at, is various hospital wards, and there's something wrong with the ventilation in the room. So it's either inadequate, or so there's not enough outdoor air supply, or sometimes a really unbalanced airflow, where I can't remember the exact paper, but in one case there was, I think it was a SARS patient was in a bed. Oh my goodness. And then there was a supply vent really close to them, but it was really overpowered. And then the exhaust vent was partially closed. So as a result of that, it was like creating this like turbulent air that was pushing the droplets past this SARS patient, and it wound up making some other people sick. So this is not surprising. The important thing to notice here is that when we're talking about these ventilation related outbreaks, they're affecting people that are sharing the same room at the same time. The reason why I'm making a big deal about that is that when people in the media see, oh, ventilation related outbreak or HVAC related outbreak, they see in their minds the scary virus moving into the ducts and traveling through the ductwork into other rooms and, you know, infecting a whole building essentially. And that's not what's happening in these cases. It's the people sharing the same room. Maybe it's a large room. Definitely they shouldn't be getting infected if the ventilation was working as it should, but they're in the same room. So I really often have to like emphasize to people, there's no evidence of SARS moving through HVAC systems or ductwork to infect people in other zones. So this has come up a lot where people have a building and they're going to put, there's a doctor's office on the first floor, or there's a person in the building that's sick and they want to know if they're going to somehow be impacted or that virus is going to be able to travel and reach them. And in that case, it's a no. So is the virus airborne or not? This is the question, and the problem is the word. The word is airborne. This is the problem. So it depends on who you ask and whether or not the virus is airborne. Actually, I think, Sarah, you have a poll on this. Do we want to do the airborne poll?
Yes, we do want to do the airborne poll. I am going to launch it right now. So get ready to poll, folks. We have about 100 people, 110 people online, so I'll just let this run until we get most of them answered.
That's cool.
All right, I'm going to end the poll, and then I am going to share the results so that everybody can take a quick look before we go forward. You got what you need, Angela?
Yeah, that's quite cool. So most of you figure it's more complicated than either of the above, and it is. There is no good definition for airborne transmission. As much as I look, as many people as I talk to, nobody really quite agrees on this. So if you ask the public, if it's in the air, then it's airborne. So that would include droplets and particles and aerosols, everything. It's in the air, therefore it's airborne. So, you know, case closed, easy. Another more mechanistic description of this is that this is kind of like the second option there that a lot of you liked, is that it's how it's transmitting is via those aerosols that are formed from evaporated droplets. So the droplet nuclei, as they're called, which is expanding the exposure radius and the duration exposure because they're so small and they stay suspended. However, when you pose this question to public health people, the response you'll often get, and I see this a lot in like the literature in response to the aerosol science is, well, it's not measles, right? It's not, SARS-CoV-2 is not measles. So I'm going to talk a little bit about that. Measles gets referred to a lot as a comparison because it's one of the classic airborne diseases that people are more familiar with. Measles is a disease. It's a virus that transmits easily or even preferentially through that aerosol over a long distance and longer periods of time. So it's really not a same time, same place disease like COVID appears to mostly be. So there's been cases where that measles virus has traveled many meters. I think one was a Special Olympics celebration in kind of an open air stadium. And I think that the virus traveled from one person to a susceptible contact because lots of people are vaccinated, right? So the first susceptible contact it found was something like 30 meters away. So very, very far, very distant, and in like an open air, lots of dilution. So that's quite concerning. You can also catch it from an empty room. So there's been a number of cases where somebody will bring in a child into the waiting room or into the exam room, and then, oh my God, it's measles, get out, and they leave, and then, you know, a couple hours, 1 or 2 hours later, another child comes in who's not vaccinated and manages to contract it. So you can actually catch it from an empty room. Measles is also extraordinarily contagious if you're not vaccinated. So up to 90% of the susceptible contacts will get it. So this is kind of the reason why I think public health people kind of anchor on measles. I think it's just a recognition of the fact that if SARS-CoV-2 shared more characteristics with measles, we would be in an even more serious situation than we already are. COVID is bad enough on its own. So really, when we're talking about kind of airborne transmission and the risk of airborne transmission, we need a better way to characterize that risk. And that's, I think, through two things. First, we need to kind of recomplexify the droplets versus aerosols dichotomy. It's been noted many times by prominent scientists that we've oversimplified this to the point where it's not useful anymore. And also we need a new terminology, or a new, actually old terminology, to describe infection risk and range. So the problematic dichotomy, as I've said, people have kind of started thinking in terms of droplets versus aerosols. And that's actually not what we're exposed to. They're being produced in different proportions through different activities, but they're all being produced at the same time, and we're being exposed to them at the same time. So both of them are the whole spectrum, the whole range. Look at me, I can't even stop talking about droplets versus aerosols. They're all produced. The whole range is produced by breathing, talking, singing, laughing, shouting, sneezing, and as I said earlier, the amount and the size of the droplet or the particle is really dependent on the forcefulness of the activity you're doing. So the largest ones, those are the quote unquote ballistic particles that are going to fall out of the air pretty quickly within seconds, and then that gradually becomes much longer until you get to the very smallest particles that are could stay airborne for hours. And they're not removed by settling, they're removed by impaction or electrostatic attraction, so different mechanisms than those ones that are settling due to gravity. So the larger particles, if you're unlucky enough to be in the hot zone, are infecting you by contacting the eyes, nose, mouth, being entrained and inhaled into the upper airway. Whereas the smaller the particle is, the more likely it is to get deeper into your lung. But then we really come to kind of the difference in risk. So larger particles, the larger the particle is, the more likely it is to carry more viruses, one or more virions. Whereas the smaller it is, it's actually much, much less likely to carry even one virion. So you can actually be producing aerosols, and we're not totally sure about what proportion of those small aerosols are actually carrying viruses. There's some modeling that suggests that they would carry very few. There's some work from cough aerosols from, I think, influenza that suggests that that virus might actually be preferentially in the smaller fraction. So that's definitely an area that needs to be expanded more. But the kind of idea is that you've got to be closer to catch the more risky droplets. And the farther away you are, it's getting less and less likely that you're going to capture enough of the less risky droplets to actually establish an infection. So this is a figure from Wei and Lee from 2016, and these guys really they hit the nail on the head in my view of how to talk about these things, because they talk about kind of different ranges. They talk about a close range droplet-borne route that is the droplets and the aerosols mixed together. There's kind of a short range aerosol route that is the just the aerosols kind of separated out after what we call the droplets have fallen. And then there's a long range airborne route, which is transmitted by aerosols as well, but assuming the ones that can remain viable for that long, or that, are infectious enough that you can get a disease even with a very small number of particles. So as I've said previously, your risk is really a factor of exposure and time. And so this is, I think, rather than talking about droplets and aerosols, we need to be talking about exposure and time. So as I've said, COVID is from what we see from these epidemiological studies or outbreak studies, we're really, I think, looking at the short range aerosol route, which is how I now talk about this. I don't use the word airborne, I talk about short range aerosol, just to let people know that, yeah, it's an aerosol. Yes, it can, if not establish an infection, at least augment an infection, and but it's not something that's traveling long range. It's not traveling to different rooms or buildings, etc. So I'm talking a lot about public perception and the kind of inquiries that we get at the NCCH and the concerns that we hear. So I want to just touch super briefly on this. I don't have a ton to say, nor do we have a ton of time, but just kind of this idea of risk communication in not only a post-truth, but a post-trust environment where, being a scientist doesn't get you credit anymore because there's just so many scientists and doctors on Facebook. So I guess kind of my point here is that today we're talking about the aerosol science and the epidemiological data, and these kind of two bodies of work are still dialoguing. We're still trying to figure out how important aerosol transmission is, and it's going to take some time to really get a fine-tuned understanding. However, others are already out there blogging and Facebooking, and their messages are not always factual or reasoned. Some of that may be metrics driven, you get more clicks and likes and hits and retweets if you say something really scary like it's airborne, it's in the vents. There's also a lot of commercial opportunists out there. I've been just receiving some crazy emails about different products and technologies that are, you know, going to save you from the virus, and so you don't have to wear a mask. But there's also people out there with a truly malicious intent that are trying to foment panic and strife. And so, you know, misinformation and disinformation about science are out there. They're active, one would say even out of control. I've actually had some great reading on this if anybody's interested. Generally, if you are interested in this topic, reach out to me and let's talk about it, because I think I have some other things I'd like to do around this particular area. But just for fun, just for now, I like to ask you guys what degree and how you feel that you as scientists should be engaging with misinformation or disinformation. So Sarah, you can pull that poll up. I'll just say misinformation is incorrect information, well-intentioned but stupid. So incorrect information, whereas disinformation is information that was deliberately created to mislead or hurt.
I am launching this poll.
Cool. Incidentally, you can't dance fight them on TikTok anymore because, well, I guess you can in Canada, but I read in the Washington Post this morning that Trump has banned TikTok.
Just waiting for the last few to trickle in here. And end poll and share results.
Yeah, that's great. I think that's where most of us really sit, is that, you know, all of us are very, very busy. I mean, this is actually kind of my job a little bit more than other people's job, but some people are just, you know, focused on their work and that's what they can do. There are ability issues. I am not a social media warrior, so I resonate with that. I feel like a lot of us do feel like we could contribute better through collaborations that, you know, share the capacity and share the ability. As for that, those 5 disinformation warriors out there, I salute you. Keep up the good fight. All right. So now we've talked about kind of like the role of ventilation in those outbreaks, and, you know, it's kind of obvious that obviously we want good ventilation indoor spaces that will protect people. So I do, however, want to point out one pretty serious limitation of ventilation as a mitigation measure. And this is a figure that I took from Maraska et al. 2020, Lydia Maraska. They've made a really great point, and they've been very effective in communicating that if you have good ventilation, if you use some air cleaning technologies, if you avoid recirculation, you can prevent the accumulation of those aerosols in a space. It's totally true. You can reduce your exposure if you're farther away, but I mean, in this case here, you're really, the ventilation is a means to kind of like reduce your exposure overall and your risk of transmission. However, if you're that guy right there, if you're this guy right here, right in the thick of it, ventilation is not going to protect you right there in the hot zone. So although ventilation is an excellent support and it's necessarily, we need to be ensuring that rooms are properly ventilated, it's not a solution. The key focus always has to be in these indoor spaces to reduce crowding, because there's nothing else, you know, short of universal masking that will protect people, as well as just like, well, even masking, there's nothing that protects people more than reducing crowding. So there's also a lot of challenges to using ventilation as a mitigation measure. Non-hospital settings are ventilated for comfort, not for infection control. So most residential and workplace settings are just not really well not really well ventilated to begin with. They've got different modifications, furniture installations that disrupt airflow. They may not be maintained. That's pretty common. A lot of people don't understand the technologies they're using. They think that the mini split air conditioner up on the wall is bringing in fresh air when it's not. Another big challenge in cold and very hot climates is that you have to pay to heat or cool all that outdoor air you're bringing in. So you either have to increase your costs or you have to sacrifice your thermal comfort. And then of course, there's wildfires, and wildfires turns all of this upside down. And this last week, there's been a lot of confusion with the schools reopening, and they were provided a lot of good advice on ventilation and windows open. And now, that needs to be modified very quickly because the risk of the smoke exposure. So when we give advice on ventilation, there's no one size fits all. I often tell people, you need to consult an HVAC expert because building systems, they all have very different setups. It's really hard to provide specific advice. So many of the professional organizations out there like ASHRAE and REVA have produced guidance documents, but they're essentially like menus or laundry lists of different things that can be done. They don't necessarily always point people towards the most important thing. So you kind of have to figure out what you can do, what's reasonable to do, but you might not always have very good understanding of what would be most effective to do. This kind of uncertainty really leaves the door open for that opportunistic marketing. So WorkSafe BC has a general ventilation air circulation FAQ, and this is something that me and Sarah worked on. The kind of very basic principles we put out there is that people should be ensuring that their ventilation system is working as it's specified to do according to specs, and to keep it running. Nobody should be turning off ventilation systems. Although Sarah may want to comment on that with the current wildfire situation. Maintenance needs to be done, filters need to be changed, air supply and return needs to be balanced so that you're not getting drafty, strange airflow. Reducing recirculation is great as much as you can. Increasing outdoor air is great. You can also open windows. Air cleaners are okay. In fact, right now they're great. If you have an air cleaner in your residence, you are one of the blessed since they're sold out everywhere. But if you have an air cleaner for COVID, you can't rely on that to protect you because it really depends where it's placed and, if it has an appropriate clean air delivery rate, and also, just if the filter has been changed or if there's like a little leak that could be allowing bypass, things like that. It's not something you can rely on to protect you. Fans and AC are okay if the room is already ventilated. So you've got some fresh air coming in, you're not just recirculating the existing air. And as I keep saying, no crowding. This is just the number one thing, is that we need to decrowd spaces, and improving or upgrading your ventilation is not a way to increase the number of people in the space, because ventilation will not prevent that close contact transmission. So I have a ventilation blog at our website, which kind of goes through some of these details more and, a bit more wordy. So you can look for it there. So knowledge canyons, one of the bigger ones, a lot of people want very specific advice. So thing that I have to kind of point out a lot is that we don't actually have a very good quantitative understanding of the relationship between ventilation rates or technologies and their impact on transmission. So we can't say you need X number of air changes to reduce this number of infections. We don't have that kind of level of understanding. We need to understand the relative value of interventions better. So Mike's talk last week on ventilation versus masking, it's a great contribution. Air filtration is, something where I'm becoming more and more in support of air filtration with our current smoke situation, but it's, indoor air quality in general is something we need to be improving and planning for, respiratory diseases, but also our yearly fire season is, something to think about. And just generally, this is a marathon, not a sprint. So we need to really focus on where to best spend the resources and not just kind of react and potentially spend money we're going to need later. So I wanted to say one more thing about sewage stacks versus HVAC. I don't know, maybe this might be a little bit out of the blue, but there has been a couple of events now where a fecal virus appears to have been aerosolized through the plumbing system. So Back with the first SARS, there was a very specific and sad event at the Amoy Gardens where some faulty plumbing and a dry drain and an overpowered exhaust fan actually all worked together to aerosolize the SARS virus out of a pipe where somebody had had diarrhea, and there was a really large contribution, but it was aerosolized out of the pipe and actually out of the unit into the air, and it actually spread to other towers, and it killed about 200 people, or pardon me, infected about 200 people, and it killed 42 people. So it's really serious. And then, you know, that seemed like a very specific kind of one-time thing, but there's actually been a couple of similar instances. So for example, in that Hongmei house in Hong Kong in February, that again was a situation where there was a infected case on one floor, and then the person directly below that person became ill. And there was very low, I believe, community transmission at the time. And so it was really hard to explain other than the fact that they were connected by a sewage pipe or in a vent pipe. And so there was also another mention from the Chinese CDC about a case where two families, I think, were actually 10 floors apart or something like that. I think I'm getting the two Chinese cases mixed up, but there was also a case in Guangzhou where they actually found SARS-CoV-2 in the bathroom of a long vacant apartment. So there may be something, this may be actually more possible than appreciated. I don't think it's a common occurrence, but the reason why I'm interested in this is because we put all this focus on HVAC, where the HVAC is actually a diluting mechanism. So the dirty air gets sucked away, it gets filtered, which removes the virus, it gets mixed with fresh outdoor air, which dilutes the virus, and then it gets put back on, or put back into the building. So that's a diluting mechanism. It's very protective. Sewage stacks are interesting because they're actually a concentrating mechanism. If you've got a number of sick people in one unit, everybody's pooping into the same pipe. And so you're concentrating your contributions in one place, even with like water flushing through. And then if there is any sort of, there's actually a variety of ways this can actually happen, but there can be kind of like a faulty plumbing or even environmental conditions where there's some condo towers will have bubbling toilets when there's a really high wind. And it's because the vent stack opens to the roof and then the wind blows over top and there's pressure changes in the vent pipe, and then there may be some burping in the toilet. So this kind of faulty plumbing or environmental factors, there could be potential for something like that to happen. I think at least it's more likely than HVAC. So I am not trying to create a panic. I think that this is going to be a very rare occurrence, but it's something that if there's an outbreak, especially in a residential building where there's really no other explanation for it, like a personal contact explanation, this might be something to look at. And I would certainly be interested in hearing from anybody who has any more information on this, just kind of to give me context. I love how I use my presentations to ask other people for information. So just to sum up, the key messages here are that kind of close proximity and duration are key for transmission. Sharing those in unventilated spaces is a risk factor, but upgrading and amping up the ventilation is not going to solve these kind of transmission problems. Certainly it's not going to prevent close range transmission. So generally we're telling people to make sure that your HVAC system in your workplace, in your condo building, whatever, is in good repair to promote health and comfort, right? There's other ways that people get sick in this pandemic besides COVID, right? That's also just indoor air quality is important because it is. Yeah, this last point here to revise your pandemic protocol really applies more to, I guess, workplaces and residential buildings, just that, you know, ventilation is something that needs to be considered and planned for. But at the same time, not in the absence of other infection control measures. So thank you very much. My address, or my email address is up here, and I really encourage people to email me with questions or information or more papers. I get a lot of value out of these kind of interactions. If I don't have the answer for your question, just please email me and I will connect you to one of the other amazing BCCDC people who will probably be able to answer it. If you're media, if you're a reporter, you need an interview, rather than asking questions here, please forward those questions to the BCCDC comms officer, which is Heather, and then I'll talk to you not in this environment. And yeah, that's it for me.